So today I'm going to present a case that we were involved, the surgical people were involved, the medical people were involved. It's a case that's quite rare and interesting. The case starts with a 78-year-old man who came in for a Whipples for a head of pancreas adenocarcinoma. He had a background of type 2 diabetes that he had for about 15 years. He was just recently started on insulin about 6 months before presentation, but there wasn't any evidence of end organ damage from the diabetes. He also had acromegaly, hypertension, obstructive sleep apnea, and he had a past surgical history of cholecystectomy and having his appendix out without any complications. His medications were insulin, metformin. He was on a proton pump inhibitor. He was on prednisolone for his hypertension, aspirin, and he was on a long-acting lanreotide, which is a somatostatin analog for his acromegaly. His only allergy was iodine. He got a rash with that. In terms of his intraoperative management, he received the epidural at the level of T7/8 for post-operative pain management. His general anesthetic technique was standard induction with fentanyl, propofol, cisatracurium, and his maintenance was on sevoflurane and infusion of a cisatracurium. His epidural management during the operation, he received 8 mils of 0.25% bupivacaine, and he was at the end of the case started on 8 mils an hour of a standard mix. Now in recovery, he was quite comfortable. His infusion was running at 8 mils an hour. He had a sensory level that was appropriate, T4 to L1, L2. At that stage he had no motor block. He was hemodynamically stable in recovery, and he went to the ward. Day 1 was uneventful. On day 2, he reported some leg weakness. Now, the left leg was weaker than the right. He was able to perform a straight leg raise on the right, but I don't have much more information about that day. I know the sensory levels were on the right, it was T4 to T10. The left was T4 to L1, so a bit stronger on the left side, perhaps explaining his left leg weakness. At that stage he had no back pain, and the decision was made to decrease the epidural infusion from 12 mils an hour to 10 mils an hour, and this helped to resolve the leg weakness. But later on that evening he got more pain, he was seen, and the infusion was increased again to 12 mils an hour. Now in day 3, he had leg weakness. He was, I'm not, from the notes I'm not quite sure which leg or both legs. He wasn't able to perform the extension. At that stage, as we mostly do, day 3, remove the epidural. We removed the epidural in the morning, and PCA fentanyl was commenced. But shortly after, about an hour later or so, he complained of pain, so he was seen. A ketamine infusion was started at that stage, and at that point it was noted that the motor weakness was actually improving. Now it was only day 4, the next time that I think we saw him, that he complained of more lower limb weakness. He wasn't able to mobilize at this stage, and he also had some upper limb weakness as well, associated with some paresthesia in his right palm. Neurological examination at this stage revealed quite a weak lower limb, power of 2 out of 5 in most muscle groups, except for his ankle plantar flexion, which was 3 out of 5 at that stage. It was fairly symmetrical. His upper limbs were also quite weak, not as weak as his legs. They scored 3 out of 5, but his shoulder abduction, his proximal muscles, were weaker, 2 out of 5, and again this was bilateral. At this stage his tone was normal. His reflexes couldn't be elicited. We don't know much about his bladder or bowel because he had an indwelling catheter in, but at that stage there wasn't any definite sensory level, and his proprioception and vibration were normal. So at this stage, the differential, we had to rule out an epidural related cause. Hematoma was probably number one thing to rule out. Infection would probably be too early, and we think direct trauma would have presented earlier perhaps, and it wouldn't have resolved. Other thought was whether he's had an infarct in his anterior part of his cord. The symptoms and signs would fit with that. His posterior column was spared, so that would fit with that diagnosis. And he was actually started on some aspirin. This is a man who's got cancer, so we have to think about metastatic disease causing cord compression. Other thoughts that may explain it was some kind of cervical disc herniation acutely. Now it could also be obviously something unrelated, for example Guillain-Barré or acute transverse myelitis. So to figure this out, simple test initially, blood. There was no raised white blood cell, the platelets were normal, and always worthwhile to check the electrolytes, whether they're causing any generalized weakness, and they were all normal, fairly normal. And with any case where neurology is involved, you want to look at the B12 folate. They can cause neuropathies. The inflammatory markers were normal. So far everything was normal. Obviously he scored an MRI. MRI brain was done, that was normal. There was no collection, no hematoma, no abscess, and the only thing that they commented on was marked spondylitic changes throughout the spine, and at one level C5, C6, C7. As you can see from the arrow, there's some disc protrusion causing some indentation on the cord. But the radiologist didn't think this was an acute problem, so this was more chronic, long-standing. So the next important test was a nerve conduction study, and this is the first time we found some abnormality, and in summary, they thought there was a demyelinating process. So we've got a demyelinating process that's come on fairly acutely. And in terms of ruling out other differentials, lumbar puncture was done. So immunology for ruling out multiple sclerosis. The protein's important to have a look with Guillain-Barré. It can be raised, that was normal. And they also looked at the white blood cells, and there was no increase in cells. So by that time it was about day 7, and this man's weakness had got much worse. So his legs were now, the power was 1 out of 5, only a flicker of movement. His upper limbs also became worse, 2 out of 5 at this stage, and so he was admitted to HDU for monitoring. So far, the only positive findings were the nerve conduction studies and this clinical history. it was suspicious of Guillain-Barré, so immunoglobulin therapy was started. In HDU, he was monitored for a number of days. Now, his lung functions were obviously monitored and by peak flow and spirometry. At the lowest point, it was around day 10, where his peak flow was 160, and these are the spirometry results, which don't look too bad. They're within the normal range. Now, over the course of his stay, actually, after 2 weeks after this incident, his upper limb weakness was improving. He was getting his triceps jerk just back. His peak flows had improved to 360 litres a minute. He was discharged from HDU. He never required any ventilation. And around 2.5, 3 weeks later, after his surgery, he was transferred to the care of the rehabilitation team. His follow-up MRI and nerve conduction studies were essentially unchanged, and finally he was discharged home 8 weeks after his surgery. At that stage, he was actually mobilizing with a frame, and his upper limb strength was about 3 to 4 out of 5, so he was recovering. Just before I go to speak about Guillain-Barré, I was just quickly going to speak about epidural abscess and hematoma, just as a quick refresher. So with an abscess, there's a classic triad that they talk about in terms of back pain, fever, neurological deficit. But at the time of diagnosis, they say that only about 13% of patients have these, all these complete triad. Fever and back pain are the most consistent early symptoms. Fever is quite common, and it's usually followed by back pain. And obviously on examination, there's pain on palpation, on percussion. General examination, they'll can look well, but they might be quite septic. In terms of spinal cord dysfunction, you look for obviously weakness, sensory levels is important. Reflex changes are the most objective signs of cord dysfunction. So bowel, bladder dysfunction. They might have a cauda, as they get a space-occupying lesion develops, they might have a cauda equina syndrome. They may have some saddle sensory loss. They may have radicular pain or in the distribution of the dermatome. The important thing, I guess, to note is with the abscess compared to a hematoma, the abscess progresses somewhat slower, hours to days. In terms of investigations, the white blood cells can be up in about 2/3 of patients, but not necessarily always increased. The MRI is the key in diagnosis, and there needs to be a high index of suspicion because symptoms and signs may be non-specific at the time. In terms of hematoma, it's reported to be quite rare, approximately 1 in 150,000, but that's overall. So there is a subgroup of patients, they talk about female orthopedic elderly patients who are being reported as 1 in 4,000. So it's important to know the risk factors in your patient. So elderly coagulopathic patients with spinal stenosis are going to be at increased risk. So when you're trying to figure out the risk-benefit ratios, obviously multiple punctures is also another risk factor. The interesting thing about spinal stenosis is that when people have done blood patches, they found in the young patients the blood actually, when they do MRIs, the blood escapes from the intravertebral foramina. So someone who's got spinal stenosis just doesn't have that, I guess, escape route. Hematoma progresses over minutes to hours or faster. They can also have radicular back pain, percussion concussion tenderness, and similarly signs of spinal cord compression. So Guillain-Barré hasn't come out too well. A bit of fun change. Looked all right last night. Put the words together, it's like those puzzles, eh? Before I get into it, I'll just mention why I'm talking about this case is because it's a pretty rare case. So if you do a literature search, there's only a handful of cases reported. And interestingly, in Anesthesia and Analgesia 2005, quite a similar case was reported for a 68-year-old man who had pancreatic cancer as well. His epidural was put in L2, L3, and he had a right arm weakness. It was quite profound. It happened in recovery, only 2 hours into his recovery, so quite quick, and it was confirmed by nerve conduction studies. He also had a rise in protein in his CSF, so that's why they thought Guillain-Barré was likely in that case. He did recover. He was discharged 11 days after his surgery, which was fairly quick. And at 6-month follow-up, he had no residual neurology. It's a bit atypical. I thought that case, when I'll talk about what you expect in Guillain-Barré. Another case in Journal of International Medical Research, a 68-year-old man who had hemicolectomy for adenocarcinoma, and his weakness started about 4 days later. His was more classical in terms of he had paresthesia in his toes and fingers. He had lower limb weakness, and it ascended to his arms. This fellow needed ventilation in intensive care, but he was discharged from hospital 2 weeks later after his surgery. But that was in Turkey, so maybe they've got faster discharge criteria. So that was quick. Then in pediatric anesthesia, there's been 2 cases reported. A 9-year-old who had his appendix ruptured, and I think it was a 5-6-year-old who had his femur fracture repaired. And there's a number of other cases with hip replacement, post-cardiac surgery, so lots of different types of surgery, and not always cancer related. So what's the definition? The definition is that it's acute. It's demyelinating disorder of the peripheral nervous system. It's progressive, and there's progressive muscular weakness. There's only mild distal sensory loss and a reduction in reflexes. The diagnosis really is clinical, with the investigations supporting. It's pretty rare, about 1 in 100,000. There was an outbreak in 1976 after the influenza program, but whether it's related to that or not, probably not. There's a couple of different variants, but the most common by far is the demyelinating form, but the axons can be affected as well. So looking at the diagnostic criteria, there's some things that are required and some things that are supportive. In terms of, I'll just take you to what this man had. So he had a progressive weakness involving his arms and legs. He had lost his reflexes. The progression was quite acute, so it happened within days to, it has to happen before 4 weeks. It was fairly symmetrical, so that's supportive of the diagnosis. He only had mild sensory signs. He had the paresthesia in his hand, and that's quite common. 80% of patients apparently get paresthesia. His cranial nerves weren't involved. His recovery started about 2 weeks after the disease started, so that also fits. he did not have any autonomic dysfunction, had no fever at the onset of his disease, so that's quite supportive. In terms of CSF and nerve conduction, the nerve conduction studies were supportive, but the CSF, the rise in protein that you would expect, was not. So he gets a lot of ticks. Now there's some things that are cast a doubt, and the main thing I just wanted to focus here is if there's a sensory level, you have to think about a spinal cord pathology. The cause of this disease, they think it's immunologically mediated, attack on the myelin sheath. It's mainly triggered by an infection. It's usually viral, but it can be bacterial as well. And some people talk about maybe immunization as a trigger. Risk factors, it's really the infection. They do mention cancer, surgery, neuroaxial blocks, elderly, male HIV infection, but they're all weak associations. In terms of the pathophysiology, we've talked about the attack of the immune system on the nervous system. So there's a loss of the insulating properties of the nerves, and that's what causes the reduction in propagation of the electric nerve impulses that we see on nerve conduction studies. Now once the immune reaction stops, the nerves begin to remyelinate, and that's what you see clinically. In terms of common symptoms and signs, some of the interesting ones are the back and leg pain, obviously for us, because our differential is the spinal epidural hematoma and abscess, and also because we'll may be involved in the pain management of these patients, and the autonomic dysfunction. It's also interesting that they can get sinus tachycardia, and we can have quite hypertensive or have postural hypotension, so something to bear in mind. In terms of the tests that they should order, or neurologists order, nerve conduction studies, we've talked about the slowing of the nerve conduction velocities. The lumbar puncture, Guillain-Barré, 90% of patients, the CSF protein is high, but in 10% of patients, for example our patient, they don't have a rise in the CSF protein. It's also important to rule out the differentials. For example, in transverse myelitis, you might get a rise in the white blood cells. The LFTs can be elevated, and spirometry is quite important in terms of monitoring these patients. This is a medical emergency, and patients need to be monitored quite closely. Up to 30% of patients will need mechanical ventilation. So some of the risk factors for progressing to mechanical ventilation include a rapid disease progression, bulbar dysfunction, bilateral facial nerve weakness, autonomic dysfunction. Probably the best one is inability to lift head, also inability to cough. And we look at the vital capacity, and the numbers that they quote is less than 15 to 20 mils per kilogram, and also a reduction in vital capacity of 30%. Some of the differential diagnoses that come up in the textbooks, the transverse myelitis, but this involves the spinal cord, so you'd expect upper motor neuron signs, and you look at the CSF and the inflammatory markers. Myasthenia gravis, this would be it's more fatigability really, so clinically maybe differentiated. Eaton-Lambert syndrome, that can present similar with a similar clinical picture, but the reflexes improve with exercise in this disease, and also the nerve conduction study is a way of confirming, denying this diagnosis. Polymyositis it involves the muscle, so you're going to have muscular pain. The reflexes are going to be normal because it's the muscles. The creatine kinase is going to be risen. In terms of management and prognosis, so it's a multidisciplinary approach. It involves the allied health, the social workers. Supportive management is important. We talked about ventilation, so respiratory support, cardiovascular being monitored on a telemetry. Of course, if they're not mobilizing, all the intensive care measures like DVT prophylaxis, for example. And obviously pain management is important, so starting some anti-neuropathic pain, like gabapentin. Disease-modifying therapy, there's two options here. There's plasma exchange and high-dose immunoglobulin, and they're as efficacious as each other. I think it just depends on where you are, which one you get. This is followed by rehabilitation. In terms of prognosis, the overall prognosis is pretty good. 85% will make a good functional recovery, but around 20%, there's a 20% mortality with those patients who are mechanically ventilated. That is all.
Can I just raise something? I mean, I saw this man. I think a red herring which came up is that this guy had a T7, T8 epidural, and then quite unusually developed lower limb weakness. I think that should give a bit of a high net to suspicion that it's not epidural related. The other interesting anecdote was that the surgical team hadn't noticed that he couldn't move his legs, and it was only picked up by the pain service when he came along to review the epidural. The fact that he had to be lifted by two wardsmen from the bed to the chair.
So the abdominal wound was okay, though?
Yeah, wound tip drains tip, no further orders.
I mean, that's an important point, because I think if it had been an epidural-related complication, he'd be paralysed, right? There was quite a delay there, and I think there's some lessons to be learned for the management of troubleshooting epidural.
Yeah, definitely.
And that the surgical team and our team and the nursing troubleshooting that goes on with neurological observations with epidurals. It'd be, there's some real lessons here.
Wouldn't the surgeon simply assume that if the weakness in the legs and the patient epidural is matched up with the worry about when it's
No, they hadn't noticed that the legs didn't move.
Was it documented in your trial?
No.
But the obs probably, that's the other interesting, the obs probably stopped, the neuro obs probably stopped when the epidural was removed. The pain service was only still involved because he was converted to a PCA. And so the real motor changes only seem to start or seem to get noticed after the epidural had come out, and that's a catch.
So the other important thing is phoning the anaesthetic consultant who did the case to make them aware of what's going on and what the diagnostic process is going on at the moment. So I think it's important that someone with a relatively high thoracic epidural, unusually developing lower limb weakness, you've got to think something's going on. The other thing, when the neurologist first came along, the first thing he said to me is, do you think it's something that's gone down the epidural, like the lady from St George? That's the first thing he said.
Blame the epidural until the end.
Probably addicted to some chlorhexidine alcohol. And the other useful comment the neurologist said is he didn't think it was related to the epidural because a guy had developed progressive upper limb weakness, which wasn't in keeping. And then later on, while the first neurologist said he thought it most probably was Guillain-Barré, a second neurologist came along after a couple of days when they did their big ward round and said, no, I think it could be something else, not quite typical. I suppose because the CSF protein wasn't raised.
Yeah, they had a lot of meetings
so
about it. Yeah, that's right.
Was even Lambert kind of high on their list, given that he was, had a
with a
cancer? It doesn't always have to be small, lung cancer. It could be any cancer.
Yeah, they didn't mention it
No.
in the notes as high on the list. Actually, they were coming up with other things like critical care myopathy,
Right.
and which was probably too early. Like I thought those patients have to be in intensive care for a few months. So there was cervical spondylosis and acute disc herniation was
Yeah.
high up on their list.
Sure.
But yeah.
Even though he had that disc prolapse, I talked to the neuroradiologist and he said definitely not, because there's no acute signal in the cord. That's the differentiating feature.
Yeah.
An MRI, whether it's acute or long-standing.
And I think that's a really important DD in the post-op period as well. And one thing we often don't think about, irrespective of whether they get an epidural or not, is people with, he obviously has an abnormal MRI, and these sorts of patients can get neck movements under anaesthetic that then cause an acute, often reversible but acute injury, which doesn't display itself as a full-blown, deficit up front, but you can get a little bit of edema around a tight space, and then you end up with a reversible but sort of,
Yeah.
obvious injury.
And that reminds me, that's another thing brought up by the neurologist. They saw the MRI and they said, do you think the anaesthetist did something, manipulated the head and neck during intubation? That was the other thing they were contemplating.
Yeah. Blame everyone else.
Really good to say about it.
But the epidural, I wonder if it was unmasking some kind of process going on with the leg. I wonder if, because there was that Guillain-Barré starting up, and whether it was actually, just leaving a little bit of local anaesthetic. Like, if a patient's hypovolemic, they'll get hypotensive because they got the epidural, and it just unmasks the hypovolemia.
I think probably more likely because with major surgery which you had or trauma, you do get some interference with your immune competence.
Yeah.
And maybe that led to the progressive course.
That-
Probably the most likely reason.
Oh, that's the theory for, the Guillain-Barré, yeah.
Also, the diagnostic criteria, where do they come from? Is that some neurologist association or?
Yeah, I put that up a while ago. It's one of the one of the neurology textbooks or journals. Yeah, I can find out where my reference
Just
is.
be good to reference that source.
Yeah.
I think from Pedro's point of view about masking other pathology with the epidural, I think it helps to have a regular number of epidurals going through the place, so that nursing and medical staff are familiar with what's normal neurological changes with normal sized doses of an epidural infusion, so that when people develop, we've had people go through here who develop compartment syndromes or all sorts of other, whether it's worsening sort of surgical complications, anastomotic breakdowns in the belly or whatever. And sometimes the epidural can get blamed for masking it all, but usually, in retrospect, it's pretty easy to tell what's a normal expectation of the change from the pathology and from the epidural, and it's a matter of having a high index of suspicion when you're running. The other interesting ethical dilemma, which ultimately never came up because he got better, was that this man's basically had surgery for pancreatic cancer, and a week into his postoperative course, he's getting worse and worse. He's getting worse and worse lung function amongst everything else. He's looking down the barrel of intensive care, and the time course for many of these patients is months on a ventilator in ICU, and they were starting to generate the thoughts about what discussion would need to take place here about whether someone would actually want to undergo that sort of aggressive treatment with Guillain-Barré.
Particularly if he's got cancer.
Well, the life expectancy with pancreatic cancer, even with surgery here, is months.
Well, the
a
surgery
year or so.
consultant actually said the prognosis was quite poor.
Yeah. So you'd need to be having that conversation with the patient and his relatives pretty early before you decide to embark on ventilation in intensive care, which makes all that decision making so much harder.
And I think he's quite a healthy, active guy. He just
Yeah.
And also, you mentioned about the treatment, IgG or plasma exchange. Both of those are offered here quite readily. What was the reason?
Why they chose one?
Over
Yeah, I'm not sure actually why they chose one over another. Actually, I have to ask them. Yeah.
Have we pinned a neurologist down for tomorrow?
Dr. Loy's working on it still. It's the MRI fellow has said he's got a meeting. I wanted to get a radiologist to come.
Well, the radiologist's not so critical because
Yeah.
it's actually easy to see the pathology.
Yeah,
so that's all right.
they've backed out.
Yeah, that's all right.
But the neurologist, he's
Just
trying.
someone to talk to
Yeah.
the conduction study results, particularly if it's a little bit equivocal, and the
Yeah.
CSF protein.
Yeah, definitely.
And some of this discussion.
Andrew Duggins is involved.
He's
He's on holiday.
And
We-
Clement
we-
Boyd is with.
he won't be there, so he's trying to find someone else.
Yeah, so we need a proxy. One of the joys of being a non-physician specialty is that we get the school holiday slot at medical grandparents. So it's reasonably common, but for anyone who wants to hear it all again and give Pedram's the support, we're presenting at medical grandrounds tomorrow lunchtime.
Is the timing of the treatment important? Like, plasmapheresis? Is it early you do it the better?
I think it is, but look, I don't know too much about the treatment. I didn't look at it. Yeah.
Just got a question about analgesia. I don't know if you do it as well. With the anti-neuropathic analgesics, did you get an impression as to what percentage of Guillain-Barré patients need to go on them, or do they start them preventatively once the diagnosis is made on the basis that most of them need them?
A lot of patients do have pain, and I don't know what percentage will need gabapentin, but a lot of them do suffer from pain. In terms of recovery and things, it's actually quite good. So I don't think they go on it for chronically, but I don't have percentages. But
Yeah, about 5 years ago, we were asked to consult quite material neuropathic pain with Guillain-Barré, and it was very difficult. He had a big dose of gabapentin and ketamine, so it was a really difficult problem.
it's so rare that 1 in 100,000. I don't think we come across it too much.